This is the sound of refusing to give in. It's leaving nothing to chance. Searching relentlessly for the right, the only treatment option that will keep a heart beating. Fortunately, the Christ Hospital Health Network has groundbreaking treatment options unavailable anywhere else in the country, developed with help from our own physicians. That's what makes us Greater Cincinnati's Heart Hospital and one of the top heart hospitals in the world. The Christ Hospital Health Network, everything it takes.
The Pound This podcast is brought to you by the Christ Hospital Health Network. This is the Pound This podcast, episode 805, Symptoms and Solutions to Cardiac Arrest with Dr. James Jollis.
I want to lose weight, but I don't know how to get started. What should I meal prep every week?
How do I get those sweet booty gains?
Inspiration for your healthy lifestyle. The Pound This podcast with Amanda Valentine.
Hello, friends. Welcome to the Pound This podcast. Before I get into this whole conversation with cardiac arrest with Dr. James Jollis, I do want to bring up a point that we talked about when we weren't recording, and I meant to record it, about we were specifically talking about the event we saw in the Bengals-Bills game where Damar Hamlin got hit in the chest and went into cardiac arrest, which was one of the reasons that we wanted to record this podcast. And he gave me the name of what that heart event is, and I'm bad enough at pronouncing names. I cannot pronounce this, and I wrote it down. But basically what that happens when you go into cardiac arrest with a lot of sports, you get hit really hard in the chest, and he did say that it is very rare. So I know there's some concerns with that with kids playing sports and everything else. So I did want to bring up the point that he brought up that was a very rare event. And we're going to get into all of the signs and symptoms and everything to look out for and what to do in an event that you are having a heart event or you're witnessing it happen here in this podcast. But I do want to talk about some preventative care, which is health and nutrition, your diet and your exercise. And if you need some help with that, Sarah and Team Fit With Me is an amazing team of health coaches to teach you all about nutrition, help you with your exercise. If you're having hormonal issues, gut health issues, anything, you just need somebody to keep on your butt and to keep you going while you're also learning all these things. Sarah is fantastic. She will definitely help you reach your goals. And right now you can save 10% off of month one of all packages and plans when you go to teamfitwithme.com/poundthis. And speaking of nutrition, if you're looking to make it a little bit easier and more convenient and you don't mind eating meal prep like me, I love my meal prep. Check out Clean Eats. If you're here in Cincinnati, in Newport, or in Westchester, you can go in and eat at the cafe. I got the Epic Melt. Dude, do it. So they substitute the non-breaded chicken with the breaded chicken, so I took the unhealthier choice, but it was delicious. So if you're going to eat in the cafe, I would recommend the Epic Melt. Delicious. You have your grab and go frozen meals, or you can get the fresh meals. That's what I do. I do 21 meals a week. You can do whatever works best for you. So if you want healthy eating, clean ingredients, and made locally, and not have to do it yourself, definitely check out Clean Eats, and you can go to cleaneats.com for that. And if you're not in the Cincinnati area, you can look and see if there's a Clean Eats near you. Now let's really get into a serious health discussion and talk about signs and symptoms and what you can do to take action with cardiac arrest. Thank you so much for listening to the Pound This podcast. I am Amanda Valentine. I'm very excited to talk to my guest, Dr. James Jollis from the Christ Hospital. How are you?
Doing well, thank you.
I am very excited to chat with you because, man, you have just this extensive knowledge and this amazing background of all the things that you have done and you're currently doing. So I'll kind of let you go into the background of your career and anything else you want to share about your life.
Okay, so I'm from Cincinnati, and as they say in Cincinnati greeting, if you're not from here, it's what high school did you go to? I went to St. X. After I graduated, I left. I was in North Carolina at Duke University for my career, and I've just come back and joined the Christ Hospital Heart and Vascular team. My background, I'm what's called a cardiologist, not to be confused with a cardiac surgeon. We're actually trying to replace them and not have any more surgeries, but do everything in the cath lab. A cardiologist is trained in internal medicine, and then you specialize and take care of hearts. There's a huge array of things we do, from imaging to procedures to taking care of blood pressure. And then my background in terms of what we're discussing here with cardiac arrest, it turns out as a cardiologist, the most important decisions about whether a patient lives or dies happen before they get to the hospital. So did they recognize their symptoms? Did they get attention? Did that paramedic do an EKG? Did that nurse in the ER get the right history? It's so important. By the time they get to me, if everything's gone well, they can do really well. And if it hasn't gone well, there's not much I can do. My career in cardiology is based in the intensive care unit and in the cath lab. I originally trained for cardiac cath. So that was my experience, and that's why I kind of got out of the hospital. So working on that theme since maybe 2005, starting with a kind of heart attack, and I'll tell you more about it, called an ST elevation myocardial infarction. We started organizing care in our area with emergency departments and with paramedics. And the joke is, if you get 3 doctors, you get 4 plans. And so everything kind of was stopped and moving very slowly. And I can tell you, every single healthcare professional, no matter where they are, really cares about patients and wants to do the right thing. So working with thousands of colleagues, we organized a system of care to diagnose and treat heart attacks. Pretty simple. It's made a huge difference. It's really changed the way care is done in the United States now. And that was very fulfilling. And it wasn't just me, it was thousands of colleagues across the country, some of whom are listening to your podcast. So we'll talk about 2 kinds of heart attacks. The first kind of heart attack is where the blood vessel that goes to your heart, the heart is beating every second or more. It uses tons of oxygen and it needs lots of blood flow. And what typically happens, usually it's as you get older, you can get atherosclerosis, that blockages, and then that atherosclerosis ruptures and clot forms. And when clot forms, the flow in the artery stops, and your heart the muscle starts to die. If you're going to die with a heart attack, most deaths actually occur really early on. So that's why it's important to get attention right away. So that's also known as a myocardial infarction. So in medicine, we have all these $50 words. Myo is muscle, cardial is heart muscle, infarction is our term for dying tissue. And then ST elevation, the electrocardiograph invented by Eindhoven, I believe he's Dutch, over 100 years ago, is still how we diagnose a heart attack. There's something on the EKG. You start with a P wave, work your way through QRS and T, and the segment between the S and T, if that's elevated, that diagnoses a closed artery. And the treatment's pretty simple. If someone's having heart symptoms, you get an EKG, and if it shows ST segment elevation, you call my colleagues at the hospital and the cath labs, and they come in from home day or night, and they can feed a little guide wire up into your heart across the blockage, open up the artery, and if done within the first hour, literally prevent damage. So it's a pretty cool system when it works. The other kind of heart attack that we'll talk about is what we all recently experienced with the football game, and it's also known as a heart attack. In this case, the issue there is you have arrest of your heart and lungs. And so it's basically called a cardiac arrest, and it's known as out-of-hospital cardiac arrest because usually occurs not in the hospital. And it was the 3rd leading cause of death in the United States, 350,000 people a year. With COVID in the last couple of years, that has surpassed cardiac arrest deaths. All that being said, we also saw more deaths from cardiac arrest because people were hesitating to come to the hospital to recognize their symptoms presenting later. So it's a huge cause of death. And if you look at the numbers, besides 350,000, 400,000 that die, only 1 in 10 people survive. So if you have a cardiac arrest, you're most likely not going to live. So it's a really grave outcome. And it's been that way for decades. We've just had a real hard time improving survival from out-of-hospital cardiac arrest. And so as a researcher and someone who organizes care, we actually collect a lot of data to measure this. We have something called the CARES Registry. It's out of Emory. It's voluntary. You can get a license for your state. It's supported by the Heart Association as well, and an annual subscription. And with that data, it starts with the call to 911 and follows patients all the way to hospital discharge, all the different processes. And what do we learn from the CARES Registry? First of all, half of heart attacks occur when no one's around, so only half are witnessed. you have a cardiac arrest and no one's around, it's your time to go to heaven. Not much you can do about that. Of the ones that are witnessed, 70% occur at home. So it's great you have your listeners who live in homes. That's where it's most likely to occur. With COVID, that increased to 78%, which is not surprising. We were all at home because we couldn't do anything else. So that went up. The other place where they occur, obviously, in public places, like sporting arenas, or you used to have these things called shopping malls, or maybe the grocery store. So public places. So it's really important to know what you're doing at home. And then cardiac arrest itself is broken into 4 categories depending on the first rhythm that is seen. This is probably too much detail for you all, but the first and most important that's pertinent to listeners is a shockable rhythm. So either ventricular tachycardia or ventricular fibrillation, or the box just goes off. We're not sure why, but it shocks them just like on TV. Those people can be saved, especially if it's done the first couple minutes. You get 50% survival instead of 10%. So a huge difference by putting on an AED. So that's about a third of patients. Another maybe 50% is called a pulseless electrical activity arrest. That's usually something like a bad smoking incidents like COPD or asthma, or you're just overall sick and you get what we call acidotic. That's resuscitated other ways, but also by paramedics. And the third kind of arrest is called asystole, and that's when they get there and they put the heart monitor on and just getting a flat line. And that's the worst kind to find. Usually we're getting someone very late. Survival there is very grim. Maybe 1 or 2% survive an asystolic arrest. And it's probably just because we're getting there very late. And then last thing I'll go tell you, and I'll stop talking, is where do people die? So of all the cardiac arrests in the CARES registry, 75% die before they get to the hospital. So 3/4. So if we're going to change this and make more people survive, we need responses just like the football game everywhere. Out of hospitals where it's got to happen. 25% make it to the hospital, and of that, only 10% leave the hospital. So we really need to work on the outside. So I'll stop there.
Well, with that being said, if you don't have an AED handy, like I work at the YMCA, so there's multiple AEDs, and they get checked like all the time, like obsessively. They come by and get checked and make sure they're working properly. And again, like I've seen it like, shopping malls and stuff like that, they're available. But if this is happening at home, like, do you even have a good shot at survival if you don't have an AED laying around?
That's a great question. Only maybe 2 in 100 cardiac arrests have an AED applied by by bystander, so it's very rare actually.
Okay.
And the reason you're talking about, a very important reason, basically they're just not available at home. Our current protocol actually has the 911 dispatcher asking, do you have an AED? And that often delays care because people don't know what it means. Is it like a hearing aid, or what's an AED? And you got to explain it. We've actually advocated for taking that question out of their program questions. But we do need to train everyone on AEDs as well. If I were in charge, I would move all the publicly available AEDs into the hands of first responders. That's who's really going to save us. And that's the fire department. That's your sheriff. That's your local police. They need them. They need them in their trucks. When I say truck, not the fire truck, but the F-150 they drive to the station. They got to have those and go right to the arrest. That's going to make the difference.
So without those, you're saying that those pretty rare to use those. And how important is knowing CPR, and how often does CPR save lives?
So again, CPR is super important. It doubles survival if you get bystander CPR. I recently saw figures, the HA was quoting maybe a 40% bystander CPR rate. I actually think it's much lower, but I can't answer for our area because it's not being measured. It ranges across the country from 20% in maybe rural areas to 60 to 70% in Seattle. Something about Seattle. It's a great place to have a heart attack.
Noted.
But just getting back to simple things. So let me break it down for you again. And again, I hope I'm not just giving you all too much information. I think the first thing you want to do is be familiar with how to respond. And it's very simple. It doesn't take a certificate, doesn't take a course. I think all of us have actually done this stuff. And it's the 4 C's. The first one is check. And basically 2 questions we have. Is the patient awake? And are they breathing, and I say normally? So you can have a cardiac arrest and you're still breathing, but we call it agonal breathing. It's very slow breathing. I can actually imitate it for your podcast, but it's like,
Oh, okay.
that's agonal breathing. So that's not breathing. If you have those two things, the next C is you call 911 or have someone else call 911. That's really going to make a big difference because as we said, it's going to be the first responders who are going to save your life. The third C is compress. We've gotten rid of the mouth-to-mouth piece. It's actually been tested, and it's no better than just chest compression alone. When you first go down, you've got a lot of oxygen in your tissues, and chest compression makes a big difference. And again, there's two ways to train on chest compression. One is take a course from the Heart Association or Red Cross or your employer. The other is just really fast training. You put your hands on the sternum, one on top of the other, right in the middle of the breastbone. Have your shoulders right above the breastbone. You're on your knees, and you keep your elbows locked, and you push down straight and hard. And they tell you to press about 2 inches, but no one can measure that. You just press down. You know you're squeezing the heart, and you want recoil. So as you come back up, you're feeling the chest come up, down, and up. And we do it 100 times a minute. There's a million songs that are 100 times a minute. All the old people would know Night Fever, but there's many others. Staying Alive, whatever. But just fast. So that's the compress piece. And then the last is new, I think, and really not done enough, and that's connect. So as you go around, Amanda, we were talking about AEDs. There's two really important things about them. Number one, they're designed for 6-year-olds to use. And you don't need training to use them. You just take it out and open it up and follow instructions. It may be written down or actually may talk to you. So AEDs are really designed for anyone to use. And they've actually raced 6th graders against paramedics. And paramedics can deliver shock 1 minute faster. So that sticker that says only to be used by trained personnel needs to be scraped off. It can be used by anyone who could open the box. The other thing we talked about is where those AEDs are located. So the best place is in a first responder's hand. You don't want to ever have a police officer or a fireman having to go to a cardiac arrest without the tools. They all need to have AEDs readily available. As important as a stethoscope or something to stop bleeding or Narcan or something. And the second thing we were talking about is that they've actually measured this. In Copenhagen, half the cardiac arrests occurred when buildings were locked. AEDs need to be outside, not inside buildings, not behind desks, not behind locked doors. They need to be outside. That's the only way we'll be able to get enough available to really have the increased bystander response. Otherwise, you have a cardiac arrest at 2 a.m, as you said, it may be hard to get hold of an AED. But that's the last C. So check, call, compress, connect.
Well, the thing is, where I would get freaked out. I've taken the CPR AED training 5 or 6 times now. So like for the past decade. And luckily I've never like needed that in like real world in a scenario other than like on a dummy. But I'm like, I feel like if that scenario were to happen right in front of me, it almost feels like all of this information falls out of your brain, or at least that's how I would feel. I would just almost feel like too scared to jump in there and do CPR, even though I know I needed to. How often does that happen where it's like you have somebody there to help you, but it's just almost like you go into your own sort of shock because you don't know how to deal?
You'd be surprised. People hyper-focus, things slow down. You can do it, especially if you've seen it once before, but you have more help. So if you've called 911 and even you got your phone out, the telecommunicators are trained to both have you recognize the cardiac arrest and to help you do CPR. So just put the phone on speaker, they'll get you through it, and they'll be listening. So you actually have a coach right there. But it's much easier for them. If you've taken the course once, like you have, then you're familiar with it. It makes their job much easier. But you can do it, no question about it. But that's why these things are important so you're confident you can do this. You can't hurt them. If you don't do it, they're just going to pass on. You cannot hurt them. You can only save them.
Classically, though, if we're thinking of we're going to watch a cardiac event, is it like we see in TV and movies and like, oh, I grab my chest and oh, or my arm is going numb and I obviously know that I'm going into a heart attack, or is that different than a cardiac arrest, or what are these symptoms that we're actually looking for other than just like a pass out to the ground? We're hearing that breathing that you demonstrated. That's pretty obvious, but it seems like there's a lot more subtle signs and symptoms that happen to a lot of people that we just are like, I don't feel good, whatever, I'm busy, I got to get through this meeting first, and then just allow ourselves to go into an event.
So that's just another great question. There's two issues there. One is the actual cardiac arrest. That's pretty unmistakable, and that's the two things I told you. They're not responding, they're not breathing normally. That's clear cut. But so many people go into cardiac arrest because they didn't recognize their symptoms beforehand. And that's, I think, what you're getting to right there. So we talked about it before. 1 in 3 women get heart disease. Only 1 in 8 get breast cancer. So it really is, we got the Go Red month coming up with Heart Association. It really is a women's disease. When they looked at the town of Framingham, they did EKGs on everyone in the town every year, and they found out that only half people could recognize their symptoms of heart attack. They literally had a new heart attack on EKG and didn't remember a thing. So a lot of times you don't recognize the symptoms. The symptoms of the myocardial infarction I'm talking about, which very often causes a heart attack, include anything from, let's say, your nose to your belly button. There used to be these things called party lines. It was this thing called a telephone, where you shared the same telephone line with others. And you could pick up the phone and listen to your neighbor's conversations, a party line. Luckily, we didn't have one. The body's the same way. Your heart, your lungs, your intestine, your stomach, your esophagus, they're all on the same nerve. And so it's very common to mistake heart symptoms for other organs. So I can't tell you how many people I've seen who thought they had gallbladder issues and it turns out it was a heart attack, or people who took their Tums or whatever, it was actually a heart attack as well. I've had patients tell me, a woman told me she felt like someone had pliers and were pulling her tongue out, and that was her symptom of heart attack. Oh. It can be something simple like just feeling nauseated and sweaty, and that's your symptom. And it could be even belly pain, back pain, all kinds of things. And so I don't want your listeners to walk around being totally terrified of every single crick in their body. But if it's new and concerning for you, it's worth getting attention. Of all the people coming with cardiac symptoms in the ER, only 2 in 100 actually have heart attacks. The other 98 do not. We're used to that. Who should pay attention? It's a disease as you get older. So if you are, say, a woman over age 55, not that you can't get one earlier, but I will say I almost never see heart attacks in anyone at age 40 unless they're a smoker in their 40s. If you have a family history of heart disease, or you have known heart disease, those are some of the bigger risk factors. And you're having symptoms that worry you. If they're going away, tell some healthcare professional. I know it's hard to get into your doctors these days. If it's not going away, simply pick up the phone and call 911. That's what they do for a living. They're happy to do it. If we don't get calls, we can't help people.
So like you're saying, so many women get this disease, then is there any way to prevent that really or is it just kind of inevitable at that point? If, you're listening and before you're not 55 yet, is there something we can do now? So when we hit 55, it kind of lessens those odds.
So, there's lots of things you can do. I see a bunch of medals behind your head about, I guess you're running. So yeah. I encourage everyone to engage in some physical activity they enjoy every single day, including the weekends. 30, 40 minutes is something they would enjoy. And that's as long as you can. If you do it when you're older, you maintain your independence. So it's really important to do. It also could bring out symptoms. So if you're exercising and you're starting to feel something, it might be an earlier warning sign. The next thing we all struggle with is maintaining weights. The weight issue is mainly if you have diabetes from your weight. That's something that is really important to address. And there's actually It's really hard, but there's therapies and approaches to that. The next thing is never, ever, 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 ever smoke, period. Um, if you look at the numbers, 1 in 20 eighth graders smokes, 1 in 4 to 5 high school freshmen smoke or are using nicotine. If you start doing that at that age, you're likely lifelong addicted. The best class I ever given as a cardiologist was to preschool kids whose parents tell me they will never smoke again or ever smoke. Cigarettes just are really bad for you. The next thing would be take care of yourself. So there's certain conditions. If you treat high blood pressure, which by the time you're in your 60s, 4 out of 10 people have, the stroke rate goes way down. Strokes people think are worse than death. So checking your blood pressure and treating if it's high. And then you talk about diabetes. You want to avoid that if you can. If you're prone to it, your diet control, weight loss, that type of thing. Those are the main things you can do to avoid heart attacks. The one that's really hard to change, and then cholesterol. So it's amazing how much is out there about the right diet, the magic diet, this whatever, all these potions. I think the average American spends $300 a year on things that have no medical evidence. You can get, let's say, in the front of Whole Foods. But there are very, very effective cholesterol medicines as well as ways to keep your cholesterol down. I don't know the right diet. I've been doing this my whole career. I do not know the right diet. We used to say no fat, no one lost any weight. The Atkins came along and said, no, it's carbohydrates. We tested randomized trial head-to-head, worked just as well. Cholesterol came down, people lost weight. I see lots of patients, and some are very successful at their diets. And I think it's worthwhile paying attention to it. You can look at certain things. If you're looking at, for instance, soda with tons of sugar in it, or you have certain bad habits, it's probably not good for you, but it's probably everything in moderation. And there is no magic bullet for what you eat, I don't believe. At least we don't know it yet. And then we have good therapies for cholesterol. That's an issue. Super effective therapies. If you want to raise the hits of your website and increase your advertising money, you could say something bad about a statin, for instance. But honestly, heart disease, where I was in North Carolina, is now the number 2 killer, not number 1. And that's because of stopping smoking and because of very effective therapies, both preventive like statins, as well as effective treatments like the systems I'm talking about.
That's awesome. Well, I have a random just question. I don't have any idea if you have the answer to or not, or if you've studied this at all in your research. But since smoking is such a big no-no, and it feels like I don't see as many people smoke cigarettes anymore as I see vaping. Is there a difference? I mean, obviously both are probably not beneficial to your health, but is one worse than the other? Like, can vaping affect you even more so than smoking a traditional cigarette?
I think if you're already addicted to nicotine, switching over to some method like vaping is a better way to go in terms of your risk, whether it's lung cancer or whether it's heart attack risk. But I think the challenge is, there are no randomized trials for nicotine, vaping, and also it's super addicting. And it gets in the teenage and younger population, and it's a huge problem. So I think the FDA is currently wrestling with that exact issue. And I think we've seen how it's gone so far. And we have a whole new generation of kids now addicted to nicotine. They're going to have to deal with that problem. But if you're already smoking, I think vaping is better, but I'm not advocating for it.
Yeah.
I can tell you, I've taken care of a ton of people, many of them addicted to cigarettes. The numbers are only 3 in 10 can quit, only 3 in 10.
Wow. And
it's not a personal weakness. It's just super addictive. It takes over your body. You have to have it to live. Of the ones who quit, we have things like nicotine gum, like you're talking about, using vaping, etc. In my experience, what really makes a difference is just deciding you're going to quit. And then every single day you have to have the same decision, because as soon as you have one, you're back on them. But I've seen many people quit, and the ones who have been successful just go cold turkey. And that's kind of the best approach. I hate to say it, but that's what you got to do.
I mean, I never was a smoker, but I feel like for me, because I had a drastic lifestyle change, and I feel like that was kind of one of those things that worked for me, of like, as far as movement and diet goes, which it used to be like completely, really, really horrible, and a lot of binge eating disorder and fast food addictions and everything else. So I feel like it was one of those things where it's like, you have, for me in that instance, which I feel like is just as hard, because it's like that's also your lifestyle, and in addiction to that lifestyle of making that hard decision of like, I need to change and I need to feel better mentally and physically, and then it's every day for the rest of your life focusing on that goal of like, I'm going to choose the broccoli versus the nachos. Not all the time, in moderation, but you know what I mean.
I think you have to enjoy life. It's short. You take things just as they come. And if you just happen to start smoking when you were, 14 years old and you can't quit, we just have to deal with that. You can't go through life feeling bad about yourself.
Yeah, exactly. And that's where, I know so many people that smoked in high school and didn't, and had a lot of issues with that. And it's like one of those things too. I feel like with anything that's just life, and you got to figure it out and not be your own bully through the process, because that's not really going to make any solutions, I don't feel like.
Yeah.
It's kind of compounding onto it. So if anybody else had any sort of, questions or resources, is there any place to go to? Do you have any recommendations, any videos to watch, any things to read, anything like that?
I spend most of my day answering Google searches and stuff, so I think the public knows where to go. I think there are reputable sources. We talked about the Heart Association earlier. I think anything that's published in a randomized trial, I think there's a lot of material written for the public out of places like the Center for Disease Control or the FDA. Also, other countries have good literature out there. There's a lot of great sources. I think if someone promises you, eternal life and just take the special potion, that's probably not a good use of your time. And so just normal, smart things to do. And then I think if you have questions, physicians and physician extenders and nurses, a lot of our job is translating. And I think what was been hard the last few years is how much doubt there was in what we say or what we recommend. But honestly, the word doctor is Greek for teaching, and I never mind questions from patients about anything they want to ask about. And it's my job to put it into clear terms and tell them what we do know and don't know. So I would just say, as they always say on TV, ask your doctor if you're having, whatever.
Awesome. Well, I know that you mentioned that you're new back to Cincinnati, so welcome back to Cincinnati, and I'm glad that we have such an asset at the Christ Hospital.
Thank you.
All right, Dr. James Jollis, thank you so much for your time.
AmandaValentineBites.com